Asia's #1 first center, and we here proton therapy. So we are treating patients all over from like internationally global patients are coming here from like we are treating all the VIP cases from abroad, as well as it is not only from Southeast Asia, even we are getting patients from Europe and everywhere. So what is the big thing about proton? The thing is, normally when we give radiation, when when they are giving radiation, radiation is given for mainly for CA, cancer treatment. When they are giving this treatment, there will be always entry radiation. So suppose in case, can you all able to see my cursor moving here? Is it?
Yeah, yes,
okay.
Sir.
But this is all about proton. So when there is the proton beam is actually it is a very it is you all know proton is positively charged particles. So we can be able to manipulate it very well. We can control that very well. So when it is coming out of the tube, when it is coming out of the equipment, by the magnets, by using the magnets, we can actually modify it to certain level, so it can give radiation accuracy in sub-millimeter level. So we can actually able to paint the areas wherever we want, exactly where we want, and what and all dots, small dots we can see, and only to that area we can give the radiation. There won't be any excess radiation to the other tissue. If you see this, it is literally like a painting the tissue. This is a human tissue. When you are seeing it, you see how it is. It is literally like painting that particular tissue. So only the effective radiation will be only in that area by the use of control magnets. Since protons are heavily charged particles, by magnets we can manipulate it very well. So that is a major thing about it. There won't be any extra radiation. So where and all it is effective. It is effective in pediatric cases. Since in pediatric cases we should not give more radiation. So in that cases it is very effective. And other than that, it is very effective in brainstem lesion. Suppose the patient is having a lesion in brainstem or adjacent to that. If any area is adjacent, if when we are giving radiation to certain area, adjacent to that, if there are very important like optic nerve, or even the brainstem is adjacent to that, we can avoid radiation in that particular area. So suppose if there is a lesion, in a area nearer to the brainstem, we can give radiation only to that area, not to the brainstem, because brainstem is actually more sensitive to radiation. Likewise, optic nerve, optic tract, and optic chiasma, all these are very sensitive to radiation. So we can even avoid that. When we are giving radiation, we can give only to the area where there is CA, where there is cancer. We can avoid the other areas, adjacent areas. So and not only that, the radiation will also there will be optimal delivery of the radiation will be only in the tumor cells. You see this is tomotherapy. You see this radiation, okay? I'll show you some planning actually. What is planning is, before giving the radiation, since all this everything is computerized, the computer only going to handle it. We can, at the time of radiation, we can't manipulate it much. But only when we are planning, it is very important where to give what kind of radiation. So this is a case of sacral chordoma. If you see, the maximum dose is given in the sacral chordoma. That is, sacral chordoma is sacral bone tumor. In that area only, in the red line you are seeing, that is a maximum radiation. Then this radiation area is getting faded, and after this area, there is absolutely no radiation. This is only achievable with proton plan, not achievable with other plans, and we can able to avoid other areas also. Other than that, if suppose I don't want some important structure is here, I want to avoid radiation, we can able to avoid it. So when you are comparing these plants, the effective radiation, if you see, this is a normal tomotherapy plan. This is a proton plan. This is normal tomotherapy plan. Here you see this radiation only to that area, but when you are seeing here, you see in tomotherapy that is normal. Other than proton radiotherapy, there is radiation here, here, in this, almost all over the pelvis, which is very, very harmful. So this can be avoided by using proton. But at the same time, proton is much costlier compared to normal radiation. If normal radiation costs you around 2 to 3 lakhs, but in proton actually it is 25 lakhs. So that is the difference. Our radiologist, what is the part of radiology in this proton planners? Actually, we sit and we actually plan that when our radiation oncologist sit and plan for this. Actually, we also sit with them and we give our opinion in the planning. So, what are the major structures there, and where and all it is, where and all this CA is there, where and all it is extended. All this will be like we are the ones, radiologists and the radiation technicians, even sometimes we are the ones to help them. So this is also our duty. And this is normal IMRT, that is normal radiotherapy, and this is proton therapy. So when you see this and see this area, so absolutely, like this is the almost nearer to the optic nerve area. It's a case of hippocampal. Near the hippocampal region, there is see a tumor. So the area, the hippocampal is, you all know, that is very, very important. That is the major area for emotional and all this limbic system, everything there in that region. So we should avoid radiation in that area. That is possible only by proton. If you see here, the area of involvement is more, but whereas here, this area of involvement is very, very less. So all this is only achievable by proton. So even though proton has got a lot of, it is actually, proton is positive molecule, so lot of positivity. The only negative factor is about cost, because the centers are very few, the equipment is quite costly, the planning also takes a lot of time. So only with state-of-art hospital, all this therapy can be given. So these are the limiting factors. Other than that, it is absolutely well and good. And it is very, very effective in various tumors, like in the pediatric, all pediatric brain tumors, sacral chordoma, all this chordomas, and craniopharyngiomas, even in liver lesions, even in prostate lesions. These are the places where we are giving proton therapy. This is just a small introduction about proton. And I just would like to tell a few things about the post-radiation. Where we radiologists and radiographers help is needed. That also I will show you. So after this treatment, after the treatment, our important, they have given proton therapy. Now, as a radiologist, it is very, very important for us to tell few things. That is, the patient is, whether of post radiation, is there a complete response or a partial response, or it is stable disease or progression. These are the four things what is needed. The clinicians don't expect anything other than that. And here also, like, there is There will be radiation necrosis, and there can be even pseudo progression. These are the challenges what we face. There will be pseudo response, and the tumor recurrence can be there. We should tell this also. So there are two different criteria, whether it is response criteria and is there any other complication or any other it is pseudo or tumor recurrence there or not. That we should tell. So when to do this, that is very, very important. So mostly if they are giving any steroids and all, like corticosteroids and all, there will be a lot of what is it? It will be reduction of tumor and edema. All those things, whatever flared up earlier will be very less minimal. It won't be shown that much. But later on, when you do a repeat study, it will be seen again. To avoid that, you always should. So these are the criteria which I told: complete, partial, that is stable disease or progression. These four things we should tell. So we already have technical. I'm going to tell only about technical things. So already we have T2 flare this thing modality where we will be seeing hyper intensity in tumor cases, and spectroscopy already we have. But post treatment, these things won't give any solid evidence whether the tumor exists or not. That is the problem. So there will be post-treatment enhancement area, post-contrast enhancement area will be there even in post-treatment areas also. So it is very, very challenging whether to tell that a patient is having tumor residue or is the complete response is there or not. That is very, very important. For that, the main thing is T2 perfusion. In CNS tumor, we are using T2 perfusion to rule out whether that tumor exists or not. So if you see, it is like even though this is whether it is tumor progression or not, that we have to tell in this case. If you see T2, it is bright and it looks like a mass there. In T1, for contrast also, if you see, it is like peripherally enhancing cystic area with cheesy material. But in perfusion, this is where the perfusion play a very important role. If you see the perfusion, the CBV, that is cerebral blood volume, is low. Relative CBV is very, very low. That is less than 1. It means that there is no tumor cells at that area. So what we have seen here is possibly post-treatment changes. That's why it is appears. This post-treatment changes sometimes appear cheesy material kind of thing. So you see this Swiss cheese kind of appearance. So once you are seeing this, you can able to tell that it is with the T2 perfusion. You can able to tell it is post-treatment changes. This is the very, very important thing of very, very important thing as a radiologist and radiology technicians. We all should know now T2 perfusion is playing a major role in post-treatment assessment, especially in post-proton therapy. And if you see that, again, if you see there is relatively very less radiation, very less perfusion, and there is no evidence of progression. So you see this other case. In this case, there is in T1 perfusion, T1 post contrast, there is contrast enhancement, tumor-like appearance here. In diffusion, there is restricted diffusion. In T2 perfusion also, there is increased cerebral blood volume, RCBV, that is relative CBV. Normally, we compare with the other side. This side, same mirror structure, always we have symmetrical mirror structures with God's, we are God's creation. Luckily, we have this. So when this area, when we compare the same area opposite side with this side's cerebral blood volume, if this is increased, then we can say that the relative CBV increased. So possibly the patient's if the patient is, there is a recurrence or residue of disease there or not, that we can tell. So repeat, in this case, repeat surgery done and which showed tumor in HPE, histopathological evaluation. So similar like that, sometimes there can be pseudo response also. So if you see the first pre-contrast in baseline, you see there is a nodal-like structure. This is after treatment. After treatment, if you see that there is this nodules are not at all seen, this contrast enhanced nodules are not at all seen, but in T2 perfusion, it is shown RCBV increased in that area, cerebral blood volume increase. So it means that there is tumor recurrence. That is a pseudo response. So these are very, very important. We can able to tell our clinician whether post treatment there is response or not. That we can tell. Perfusion is very, very important. But there are some limitations in T2 perfusion. Like near the skull, it is very, very difficult to see, assess whether the perfusion is less or high. Near the sinuses, it is very, very difficult. And likewise, if there is hemorrhage inside the tumor, since all the hemorrhages show high T2 perfusion, it is very, very difficult to tell whether the patient's perfusion is, that in that area the perfusion is less or high. So how to overcome is T1 perfusion. That is a dynamic contrast enhanced perfusion. It gives you clear details, and you can. It is available in very few places. Even we have recently bought this, and we are doing more. We already done more number of cases with this. This can outcome all the limitations, whatever is T2, what are the limitations of